Thank you very much. This presentation is about expanding the clinical phenotype of TRAF3, haploinsufficiency syndrome. So TRAF3, or TNF receptor-associated factor, is a pleiotropic signal protein that serves and regulates the function of several types of receptors. It is located both inside the cell and at the plasma membrane, and these receptors include the members of TNF receptor superfamily, the toll-like receptors, and cytokine receptors. When we talk about its function in B cells, it is both modified by and contributes to several types of ubiquitination events. It has a role in the maintenance of immune tolerance by regulating the non-canonical NF-κB signaling pathway. It has a role in regulation of B cell survival and its homeostasis, and is also implicated as a tumor suppressor in several types of B cell malignancy. Regarding to T cells, it is involved in the regulation of T cell response. In the CD4 T cell compartment, it balances the different types of subsets, such as the suppression of Th17 differentiation, and also a negative regulator of IL-2 signaling that ends up in an increased number of Tregs. Also, it is implicated in CD8 T cell activation. So we can say that the roles and functions of TRAF3 are highly context-dependent. So in the classification of the immunophenotypes of inborn errors of immunity, it is classified as a defect in intrinsic and innate immunity. And until a few years, we only had the evidence of this paper that talked about its function, that says that TRAF3 deficiency leads to susceptibility to herpes simplex encephalitis. Then this other paper came out talking about dominant negative TRAF3 variant being associated to recurrent Mycobacterium infection and bronchiectasis. And lately, this last paper came out that associates immunodeficiency, autoimmunity, and increased B-cell malignancy with TRAF3 haploinsufficiency. And it describes 5 families, 9 patients in all. So our study started because the publication, this last publication, coincided to one of our clinical cases. This is our first patient. He is a 36-year-old man. He had a history of recurrent respiratory infections. He had past 2 pneumonias. He was detected with lymphopenia, splenomegaly, and hepatomegaly, and was diagnosed with Crohn's-like disease. This associated to hypogammaglobulinemia and the lack of response to vaccines led to the diagnosis of common variable immunodeficiency and was started on IVIGs. He was referred to our hospital, and we asked for a genetic study that showed that he had a likely pathogenic heterozygous mutation in TRAF3 gene. The segregation family study was negative, so it suggested that it was a de novo mutation. So this prompted us to do a reanalysis of the genetic data in our patients with undiagnosed inborn errors of immunity. The objective was to identify these patients and to describe the immunological phenotype. So we did the reanalysis by screening 760 patients to find these likely pathogenic genetic variants. We used Sanger sequencing, RNA sequencing for protein expression. We used Western blot for immune phenotype flow cytometry, also proliferation test, and the patients were re-interviewed in the immunological clinic. So this is our first patient. We found a second one that was a female and was also carrying a mutation that led to haploinsufficiency. And in the segregation study, we found that her mother was carrying the same variant as well. The second patient had also a history of recurrent pneumonia since the age of 8 years. She had bronchiectasis and splenomegaly. She was diagnosed with common variable immunodeficiency when she was 15 years old, and was started on IVIGs. And after that, she was diagnosed with chronic atrophic gastritis and recently recurrent gastrointestinal infections with hospitalization. Patient 3, she is a 67-year-old woman. She's the mother of patient 2, also with recurrent pneumonias. She had interstitial lung disease, also with leukopenia and splenomegaly. She had made 2 episodes of pyoderma gangrenosum, and she was diagnosed at the age of 44 when her daughter had already been diagnosed, and they started on treatment. She had more severe gastrointestinal affectation. She had nodular lymphoid hyperplasia, granulomas, and recently a perianal fistula. So the common clinical features were the respiratory tract infections, splenomegaly, hypogammaglobulinemia, and the affectation of gastrointestinal compartment. So in the lab test, we saw an increased number of naive B cell, low memory switch B cells, and also decreased naive T cells. We did the Western blot, and these are the results of patient 1 and patient 3. They both have the expression of the TRAF3 protein, but in patient 1, we saw another expression of a smaller protein that could represent the protein of the mutated allele. Then we compare it to the published paper, and these are the variants of the families in the paper, and in red are our variants. This is a comparative table. It's really a little, but it's just to emphasize that all of them had recurrent sinopulmonary infections. They all had lymphoproliferation with adenopathies or splenomegaly. And something that were different to our patients is in this cohort, most of them had hypergammaglobulinemia and ours had hypogamma. So to resume this, we present 3 new cases of TRAF3 haploinsufficiency that seems to be a condition characterized by dysgammaglobulinemia and immune dysregulation. Comparing to the patients that were published, ours also have respiratory tract infections, visceromegaly, and intestinal inflammation. Also, in the lab results have low levels of T cells and low levels of memory B cells, and the impairment of the vaccines, the polysaccharide vaccines. In contrast, our patients had hypogammaglobulinemia and didn't have any autoimmunity like the rest of the patients. So this study, it tends to broaden our understanding of TRAF3 haploinsufficiency, but we need to identify more patients with this phenotype. And I would like to leave these take-home messages that the roles and functions of TRAF3 are highly content-dependent, that it is really important to us to reevaluate genetic studies in unresolved cases, just like in this study, because newly discovered features can aid to a diagnosis. And describing the phenotypes of patients with these inborn errors of immunity will facilitate the classification or the reclassification of these genetic variants. And that's it.
Thank you. Any question? I have one question. Has these patients been treated on probiotic or have been tried to, because the gastrointestinal affections?
Yes, no, they are with immunosuppressant. One of them is getting vedolizumab and it's working, but the other 2, they had complications with cytomegalovirus, so they couldn't really differentiate if the principal affectation was because of the virus or an inflammatory phenotype. So they're still studying them.
Okay. There's one question here.
Thank you. That was very interesting and very good pickup on the patients, because they're very difficult to diagnose, I guess, because they have high IgG.
Yes.
So you really have to test the functionality of the IgG before you can conclude they're immunodeficient. Do you have any idea what's wrong with the IgG? Because you have low memory B cells, you have poor vaccination responses. So the IgG that is there, is that clonal or is that?
Yes, well, the ones that had hypergammaglobulinemia also had impaired response to vaccines, so they are producing it, but they're not making specific new antigens. So that's what led to the infections, we believe. And our patients did have hypogammaglobulinemia, so they have a different phenotype comparing to the ones in the cohort described.
In yours it was normal, right? Not low?
In ours were low at first, but these results are when they are getting the immunoglobulins.
Yeah. And there was malignancies? Is that plasma cell malignancies that these patients have?
In ours, no. But in the cohort, there was one that had malignancies. These genes had also been associated to myeloma multiple in other types of patients. But in the three of us, they didn't get any malignancies. No.
All right. Thank you.
Okay, thank you. So, this call of this session. Thank you.